Hi, I'm Christine Swisher. I'm the Chief Scientific Officer at Project Ronin and a member of the Ellis Institute. And I'm honored to be here today to talk about how Ronin is enabling personalized decision for cancer patients. And we do this by the convergence of three things. The first is we leverage causality. We encode the clinical history or have a comprehensive understanding of the patient's journey. And then finally, we deliver those insights with transparency. And the first thing I want you to know about Ronin is that we were founded with the vision of changing the way care is delivered, starting with oncology. And in oncology, if we think about a patient's journey, there are many complex and difficult decisions at every step, from when they're suspicion of a cancer diagnosis to the actual diagnosis, what treatment they choose, whether they're doing well on treatment or they need course correction, and even into survivorship or hospice and palliative care. And currently, our approach to clinical decision-making has been suboptimal because there's a number of challenges. First, we have static and incomplete guidelines that are based on population averages. So those are not individualized for the best outcome for each patient. It requires extensive extracurricular reading on all the research going through PubMed and even going through the electronic medical record to find all the information about a patient takes significant clinician time and effort. And for this reason, intuition or our best hypothesis is used, and we're not being able to leverage all of the data and make the most personalized prediction. And so at Ronin, we think there's a better way where we can have more precise decisions powered by AI. So instead of saying all of my patients should be on treatment A based on a population average, we can look and see that maybe 2 patients might not benefit as much, a similar treatment effect, and maybe the symptom burden is a lot higher. So maybe we should try a different approach for those 2 patients. And so we have this bold, ambitious vision where every clinical decision is rooted in data, personalized for a given patient, and rendered effectively with confidence. And to do that, we need to move from systems of record and billing to a system of intelligence. The electronic medical record is a rich repository of episodic clinical data of various formats, some structured, some unstructured. But what we really want to be in healthcare is leveraging intelligence systems where every clinical decision uses that data about that particular patient and available at the right time within clinical workflow. So to deliver that, we have the convergence of 3 things. First, we have to understand the patient. Then we have to be able to predict what will happen to that patient with causal evidence. And then finally, we need to provide those insights to clinicians so they can take the right action with confidence. And I'm going to talk about each of these 3 things. So the first is the development of a comprehensive graph to the patient's unique history with all the clinical context. You can think of this like Legos, where we start with this messy, multimodal, untaxonomized data that's often locked in scanned documents and clinical notes. And we use NLP to extract, structure, and normalize that data. Even still, it's not information yet. We have to incorporate diverse sources to build that full picture of the patient and understand where that data is and show it in one place. The next thing is knowledge. To bring all that understanding to a single at a glance view so that a clinician can understand their patient at a glance, instead of taking what I've heard is estimated over 20 minutes to prepare for a single visit with a patient. And then all that total patient understanding or comprehensive patient understanding can then be used to drive what we would say wisdom, or what we have as our Lego house here. So this allows us to predict with causality. to surface relevant external content, maybe NCCN guidelines, adverse events that might be relevant to this particular patient at this point in time in treatment, and do that in a personalized way. And so all of that is built on a clinical NLP portfolio, leveraging a lot of informatics as well. And there's two things that we're doing, although it's not all that we're doing, is one, we're leveraging few-shot clinical extractors and AI-based semantic normalization to help us get to syntactic and structural normalization, as well as semantic normalization, all to a common data model. So to do that, we use things like large language models, custom NLP pipelines, John Snow Labs state-of-the-art clinical NLP models, or retrieval augmented generation for our more knowledge-intensive tasks. Then these things can be fed into either a timeline view so that they have that at-a-glance understanding of the patient, or into our predictive and causal inferencing engine to predict things like adverse events or provide personalized care outcomes. And I'm going to talk a little bit more about that in a minute. And so what are some of the challenges that we face or that we have to overcome? And the reason why we can't use a general purpose, maybe ChatGPT out of the box for everything, despite its impressive performance, is because their clinical NLP has unique requirements. We have to incorporate time and relativity into every single extraction. There are many extractions, and every single extraction has to have high validity to be clinically viable, and we have to be able to commit to the viability of that for every patient, for every single insight. And there are hundreds of thousands of insights. We leverage data sets that are often private. So a lot of large language models were not exposed to data that looked like this during their training. We need specialized clinical expert benchmarking. So while benchmarking against things like USMLE is great, that's textbook knowledge. What we need is the knowledge of an oncologist who specializes in maybe breast cancer. Then we need well-curated hard test sets, and that takes a lot of time and subject matter expertise to generate. And then finally, everything we build has to be usable, interoperable, sustainable, and scalable, such that we can deliver impact at scale for all the patients that deserve these insights. The second piece is to predict with causal evidence. And so this is the application of causal inference and versus correlative insights to drive the best action for this particular patient. And what we have built at Ronin is a causal inference engine that can simulate the outcome given different interventions. So let's say we wanted to look at, for a particular patient, given their social determinants of health, their clinical risk factors, things like symptoms, comorbidities, active problems, their cancer and treatment-specific risk factors. All of those, bringing those together to say, for this particular patient, if you gave them treatment A, B, C, or D, this is what might happen to them. Or we could look at other less invasive interventions, things like a phone call or scheduling a follow-up appointment, and really predict what is the outcome of that action. And so I'm going to walk you through an example use case of a patient who has metastatic prostate cancer and is being considered for ADT. It's a common treatment for metastatic prostate cancer to help slow their progression of their disease. So the question is, should we supplement with chemotherapy or anti-androgen medications for this particular patient? Now, if we were using predictive models, we could look at we could answer the question, what is the risk for this patient for an adverse event in the next 30 days? And that gets us a little bit close to getting an insight of what's the right choice for this patient. But with causal machine learning, we can answer how. How can we change this patient's risk? And so I think that one of the challenges with predictive ML that we really have to address, particularly for healthcare applications, when we're answering these really hard questions, we have to understand that correlations are not causal relationships. Predictive machine learning was not built to mitigate selection bias. Therefore, causal machine learning, while harder, is the better choice because it's more similar to mimic human decision making. We can make more impactful actions. And this all starts by building an estimator or a model that blends both the data that we have about a patient and domain knowledge. And so to bring in the domain knowledge, we first need to build a causal graph. If you think about your traditional predictive model, we only observe this, or we only leverage this relationship between the treatment and the outcome, this direct relationship. But actually, there are other indirect relationships like mediators and confounders that impact that and bias that result. And so it's really important that we take those into account. But let's say, so for example, if we look at this question, should we supplement ADT with anti-androgen or with chemotherapy? If we look at the data, we can see the difference between PSA, which is an indicator of progression for prostate cancer patients over time. And I will briefly note that this particular outcome required us to leverage both FHIR data, which is structured data, as data from notes, and to be able to resolve those and resolve any conflicts between what might be reported in those two pieces of data. In this simplified example, we can observe from the data that a patient's race impacts both the clinical outcome, whether or not they're going to progress as measured by PSA, and what treatment they're actually given. And so without having race in our data set and using and correcting for confounding, we could misattribute strong responses in Black patients to benefits of specific treatments, therefore disadvantaging them in their outcomes. Now, I showed you a simplified causal graph. This is what our causal graphs actually look like just for this one question for this particular patient. And so drawing each of these graphs requires deep clinical understanding, a lot of time, a lot of investigation to validate. And so this is a great place where causal inference combined with large language models can mitigate each other's weaknesses. Causal inference is a wonderful technology because it produces rigorous, logically sound results when used properly. The results that you get from these techniques when done well can get you closer to insights that you would get from A/B testing or a randomized control trial. But the challenge is it requires a lot of domain expertise, it's time intensive, and sometimes we can't even get a result. Leveraging LLMs are able to effectively encode vast amounts of data and learn from that data. And there has been initial evidence that we can encode causal information from these LLMs. However, it's difficult to enforce that logical reasoning for stable predictions. And sometimes we may actually hallucinate a relationship, and this generates an incorrect insight, and that's very dangerous in a clinical application. So if we can take the best of these two, combine causal inference with large language models, then we have an expert large language model that can provide scalable access to domain knowledge, so we can choose the right attributes of a patient or the right variables to put into our predictive models. Then we can use causal inference for stable inference of our counterfactuals. And then finally, we can generate a causal structure that's testable using causal inferencing techniques. So therefore, issue with hallucinations or incorrect relationships is mitigated. And so I'm going to jump to the results here for that particular patient who was comparing the selection of ADT plus chemo or ADT plus anti-androgen therapy. And what we found was using the methods I described was that there were 23 confounders, but we were able to reweight them across treatment groups and then successfully mitigate the confoundings. And so now we can answer this question that typically would have to be done with an RCT. And the other thing that's really interesting is because we're using both a personalized predictive model and as well as correcting for confounding, we're sort of using this like double machine learning method, specifically targeted maximum likelihood estimation. We can obtain an individualized treatment comparison for every single patient. So in this example, we can see if we look at the distribution of patients in our validation set, is that there are patients that would benefit most significantly from anti-androgens here on the left. And on the right, there's a number of patients who do not get a clear benefit from this treatment that may have more severe side effects. So there's substantial variability across patients. In a clinical setting, this result would look something like this, where the provider and the patient could have a shared conversation about what is the efficacy of the treatment and what's the symptom burden and the side effects that they might experience. So we could predict things like survivorship, time to progression, dose-limiting toxicities, and the patient can bring their own preferences to that conversation. Maybe they're optimizing for attending their daughter's wedding and feeling healthy at that wedding. Finally, our third critical element is the ability to act with confidence. So I talked about a lot of really fancy things under the hood, how we use generative AI to understand our patients, how we use causal inferencing to guide the best action for a patient. But finally, that doesn't matter if we don't have a really transparent, trustworthy human AI experience that can then drive the best action for that patient and the clinician can act with confidence. And so here's a couple things or pillars that we deliver within our workflow. The first is that we provide insights within our workflow and we always cite the source. This is something that we've done as a field very well for quite some time. But as we started to embrace more and more complex models, we've lost a bit of the transparency that we once had. So we still have to have that be part of our DNA, because what's most important to the provider is the lineage of the data, the clinical impact of that result, not the abstract measure like an F1 score. The next thing is that our user experience guides the user to an actionable insight. It guides them to the intended use, what it was built to do. So in this example, for this particular patient who's high risk of an emergency department visit, we show that they had some significant contributing factors, which included abnormal labs and pain. And you can see these action cards here where maybe they might reorder a lab, they may change some care because of an abnormal lab, they may manage pain differently. So we guide them to the right action for that patient when we have a high-risk patient. The last thing we do is we have what's called a model card. And our model card sits within the user experience. The model card succinctly, in human understandable terms that are understandable in the amount of time that the clinician has to make a decision with this data, is presented here. So you can see it's just 2 lines and very simple to understand. We have the attributes about the patient that are increasing and decreasing risk so they can see the basis of our prediction. And then we have the patient, what we call the patient comparison breakdown. But really, this is about the relevancy of our training data and the patients that we have in that cohort and how that applies to this particular patient. Therefore, we have the transparency, the accountability to say, for this patient, we have strong data to support that this is an accurate prediction. And for this other patient, maybe it's a neuro-oncology patient. They're on their 3rd line of treatment. It's a rare cancer. We might not have a large cohort, well-powered cohort to power that prediction. And they can take that into their decision-making. This powers trust and is really a really strong way to be accountable. So in conclusion, we leveraged three things. We understood our patients with a comprehensive grasp of that patient's unique history and clinical context. We predicted with causal evidence. So we use causal inference in addition to predictive models to drive the optimal action. And then we had a transparent human AI experience that can allow a clinician to act with confidence. And really, this is what we're powering. I like to stay grounded in the why. And the why here is that we want to power this conversation, the provider to understand their patient quickly so they can spend more time with their patient. For them to have that conversation about what that patient's preferences are and personalize that each clinical decision for that particular patient. And so this is really what we have set out to do, and it is a really exciting mission to be on. And so with that, I invite you to learn more about Ronin. We have our white paper on responsible AI, as well as a number of publications on this that I shared today. I also mentioned that we are hiring, and we do great science, but we also have a great team, and it is such a fun place to work. We are fully remote, but we get together and twice a year and have a great time together and have a really special culture. So with that, I'd like to thank you, the Ronin team, for your time.